Both of our speakers tonight have very extensive knowledge and experience with blood-based testing, and they're both very great resources in this field. So with that, it is my privilege to introduce both of our guest speakers. We'll have Dr. Luke Yuhico kick us off. Dr. Yuhico completed his training at Cleveland Clinic, and he now practices at White Wilson Medical Center in Florida. He specializes in advanced bronchoscopy and pulmonary nodules.
If we were to take all the nodules that we see across the country, across the landscape of different physicians and healthcare providers and nurse practitioners and nurses, if we were to take the different locations we're at and the different appearances of nodules, ultimately, we all unify into three categories. We may have different size cutoffs. We may have different degrees of speculation. We may have different biases. But at the end of the day, all of us will bring patients into three general categories. This is what we do today. Category one is the radiographic tracking category. These are the patients that we take a look at and we feel are low risk. And we say, hey, I don't think you need a biopsy. I'm comfortable monitoring you. Let me do a scan in 3 months or in 6 months. Category B is, I call it the I'm not sure category. It's a patient that we're not so comfortable putting them in tracking, but at the same time, we're not so sure about biopsy. Maybe they're a high-risk patient. Maybe the nodule is not big, not small. Maybe we're sort of not sure where to go. And these are the patients that typically we say, you know what, maybe I'll get a PET scan. And the third category is the diagnostic category. We take a look, we say, hey, this is 20 millimeters, upper lobe, speculated, active smoker. I know this is cancer, and they move to biopsy. All of us may have different size cutoffs, different biases. We may have different degrees of how aggressive or conservative we are based on how we practice, based on our location, based on the landscape, or based on our training. But ultimately, we're in these three categories. Now, this is where we are today. This is where we are with everything we've done with imaging, with PET scans, with training. Our goal is to elevate what we're doing. We're not looking to change what we're doing. We are looking to elevate it. We need to be better. And therefore, we need to take what we're doing and use what we have to be better. And to do that, we need to apply blood. 10 years ago, we didn't have blood. 10 years ago, we may have thought to ourselves, one day, will we ever have a blood test or two to help us make decisions? Well, here we are. It's available. It's been out for 5 years. Now is the time. And now we have it available to use. And the question is how we use it. So let me go over each category one by one and how I recommend using it for each category of patient. Category one, the radiographic tracking category. Okay. In this category, we see a patient, we see a nodule, we think it's low risk. We move them to tracking 3 or 6 months. We know that based on Panoptic, 17% of patients in this category will be lung cancer. No one is 100% perfect. Whenever we put someone in tracking, there will be people who have cancer because every 3 centimeter nodule starts small. Every 5 centimeters nodule starts as 1 millimeter, and it grows. So what we would like is to have this blood test with every person we put in monitoring. There was a time we didn't have pictures. Now we do. With pictures, we did our best. We've monitored. We have caught cancer. And now we need to be better. Let's take blood. There was a time it was pictures only. Now it's pictures and blood. Let's take blood and use it with every person we put in tracking. And what we want, what we aim for, is to have the patient's blood test be congruent with our decision-making. Let the patient's biology tell us that, yes, I think you made the right choice. Therefore, when we send someone for tracking in 3 or 6 months, we order the Nodify lung test. The Nodify lung test may have several results. Ideally, we would like a result of likely benign. We know that the likely benign with 98% certainty will be benign in 2 years. Is it perfect? Absolutely not. Will it miss some cancers? Of course it will. No test is perfect. But if we have a test that has this degree of certainty, okay, and add it to our clinical judgment, then we will probably be more certain and more confident in our choices than we were before. And so when we make a decision to put someone in tracking for 3 or 6 months, based on our clinical judgment, based on how an image looks like, having a blood test that tells us that based on the patient's own biology, we probably made the right choice is something that gives us extra confidence that they truly belong on tracking. However, once in a while, you'll get a different result. You'll get an indeterminate XL2. You'll get a CDT that says autoantibodies are present. And these are the patients that we probably need to pull out. This test gives us confidence in those we monitor, and it's a safety net for those that we may have inadvertently misplaced in tracking. If we get a CDT that is showing autoantibodies or an indeterminate, we can have the patient called back and move them to a more aggressive category, whether it be biopsy or PET scan, but something that is not monitoring. Again, will we catch them all? We won't. Okay, but the goal is not to be perfect. The goal is just to be better than we are today. And so if 17% of people in monitoring are cancer, if we can reduce that down to 8, then that is a win. And maybe 5 or 10 years from now, we'll have something more to reduce 8 to 4. But for now, if we can cut 17 to 8, if we can take some of these patients that we have misplaced in tracking and bring them out, then we've already done more today than we've done in the last 5 years. Next category is the I'm not sure category. It's the PET scan category. Now, PET scans are great tests, but they're interesting tests, as we know. They get glucose in their tracer, and PET scans light up. And if they light up and they're hot, they're wonderful. Okay. However, as we know, they are largely dependent on hypermetabolic activity. Okay, and therefore, the smaller the nodule, the less likelihood the PET scan will light up. Okay, so we have PET scans that light up with SUVs of 3 or 4, which I call PET lows or PET negatives. And so if we have a patient that we were already not comfortable with monitoring, a patient that we were already unsure about, and we get a PET scan, and the PET scan is low, meaning a 3 or a 4, I mean, what do we do with that result? Is it cancer? Is it not cancer? Could be a granuloma, could be pseudomonas, could be mycobacterium avium, could be inflammatory disease, but could also be cancer. If it's PET negative in a patient that we were uncomfortable monitoring, are we certain it's not carcinoid or adenocarcinoma in situ? We're not. Okay. We've had PET scans. We've had them for a long time. Okay. They've done their part to help us make decisions, but truly, they have not done enough because we are where we are at lung cancer. And so this blood test is something we can use with the PET scans to get better definition of decision making. I say, if there is a patient that we are uncomfortable with monitoring, if at the end of the day we are going to monitor this patient, let it be that I have 2 tests telling me that I'm at low probability of cancer. Because a falsely low or quote unquote false negative test is possible. Okay, I can have a false negative quote unquote PET scan. I can have a false negative quote unquote blood test. But what's the probability of 2 falsely low tests? I mean, it's possible, but it's not probable. And so if I have a patient that I was already not comfortable monitoring, and at the end of the day, if I choose to monitor the patient, let it be that I have a low risk PET and a low risk blood test. However, if any of the tests show high risk, then I move to a more aggressive category. The PET scan is a great test, but it's not perfect. The blood test is a great test, but not perfect. But let each other catch each other when they fall. And so the PET scan is hot, but the blood test is moderate risk. We move for aggressive management. If the PET scan is arbitrary, but the blood shows you an XL2 indeterminate or antibodies from the CDT, then move into aggressive management. However, if both tests show you that the likelihood of malignancy is low, then maybe we're a bit more comfortable with monitoring now because we have 2 tests and the likelihood of 2 false tests is less likely. The last category is the actionable category. These are the patients we take a look at and we know, okay, upper lobe, 20 millimeter, active smoker, most likely this is cancer, and we go for biopsy. Now, what do we do if the biopsy is not congruent with our clinical decision making? We were so sure this was going to be cancer, but then the biopsy is negative. So was our clinical impression wrong? Or was the biopsy inaccurate? I said, biopsies are not perfect. It's not that you're on the mark, but tumors are heterogeneous. Typically, we see a mass and we make the assumption that it's all cancer, but many times we have central tumor and peripheral inflammation, post-obstructive pneumonia, atelectasis. It's like a sunny side up egg phenomenon where there's the yolk, which is the cancer in the middle, and there's the egg white around it. However, in a tumor, the yolk may not always be central. And so your proceduralist may be on the mark making the biopsies, but the biopsies may be taking the white and not the yolk. And therefore, the biopsy was accurate, but not truly on the cancer. And so we have to make the decision whether to trust this biopsy or not, since it was not congruent with our clinical impression that we were so sure this was cancer. And so the Nodify lung test can help us with this too. Because if the biopsy is negative and our Nodify lung shows likely benign, then maybe we can be more comfortable with scanning in 3 months. However, if the biopsy is negative and the Nodify lung test shows autoantibodies from CDT or an indeterminate XL2, maybe it warrants something a bit more aggressive, like a second biopsy for confirmation. The other utility of Nodify lung is for proceduralists. We will have some patients that will go into a case with a pre-existing Nodify lung. Say, for example, a Nodify lung was done prior with a PET scan. If we go into a case and we have a Nodify lung that's already CDT positive or already XL2 indeterminate, it may affect the case in that we take more time. So if we go, it may increase our pre-test probability of cancer. And therefore, if we initially go in and do our biopsies and get results like macrophages or white cells or atypical results, it may allow us to take a little bit more time or a little bit more risk because our pre-test risk is higher. And so this test not only helps in decision-making post-biopsy if negative, but it also helps a proceduralist make decisions during the case as to how much risk to take during the case. And lastly, of course, if the biopsy is positive, we order the IQ lung, which we will discuss a bit later on.